started. I'm just going to introduce everyone before we start. We have Matt Anderson, CEO of Ontario Health. We have Peter Donnelly from Public Health Ontario and Steny Brown from the Dalla Lana School of Public Health at the University of Toronto. All right, I'll let them deliver their remarks now.
So good afternoon, ladies and gentlemen. We'll deliver some opening remarks and then we'll be happy to take your questions. The information in our presentation today was developed by several experts in Ontario Health, Public Health Ontario, and researchers at Ontario universities. All of this led by the COVID-19 command table. Our objective today is to share the modelling and projection data that Command Table has been using to inform our work and has been using to advise government on their response to COVID-19. We feel it's important to be transparent with the public about the scale of the challenges which together we are facing, and the important work that we all need to do to help flatten the curve. How this outbreak unfolds is in the hands of the public, in effect, in all of our hands. We can change the outcome for the province by staying at home and physically distancing ourselves from each other. Now, recognizing that we get new information about this virus and this outbreak on a daily basis, we will, of course, continue to refine our projections, our models, and our advice. Everybody should take reassurance from the fact that our public health measures so far have made a significant difference, and we need everyone to stay focused in the weeks ahead. So stay home, stop the spread, and stay safe. For media following along with the slides, I'm now turning to slide 4. There have been 67 deaths in Ontario. I appreciate that some people may see different figures from that, but those are the figures that have been processed through the integrated public health information system. And although I can fully understand that it may appear confusing or even frustrating for some members of the press when they hear about deaths reported in the media locally, it must be frustrating when the deaths count does not quite tally. But it is important that you understand that the correct way to track this over time is through the Integrated Public Health Information System, IFIS. There will just be a little lag as hard-pressed public health units insert the necessary details. The thing that is striking from the data that we thus far have in Ontario is the high mortality rate in those over the age of 80. Thus far, it is 16%. That is actually a little less than global experience, where the evidence from around the world suggests that the mortality in those over the age of 80 is actually 20%. The mortality in those over the age of 70 globally is also significant at around 10%. These are very important figures for us all to be familiar with, because it tells us that we must focus on protecting the elderly. On the next slide, for the media who are following along, you will see COVID cases in Ontario tracked against those in other countries and other jurisdictions. The thing that I must draw your attention to is the fact that there is a logarithmic scale along the left-hand side of this graph. And of course, what that means is that a small increase in the graph equates with a very large number of increases in cases. Nevertheless, in an epidemic situation, this is usually the most useful way to track the progress of a disease. And as you can see from this curve, we are following a trajectory somewhat similar to that in the United States, not quite as good currently as that in British Columbia. But I would hasten to say that when one tracks cases, it really is rather difficult to know exactly where you stand. You have to watch it extremely carefully because it is rather dependent upon who you test for the disease. If I turn to the next slide, we are tracking deaths. Now, sadly, deaths around the world are mounting. And one of the things about tracking deaths as opposed to tracking cases, they are not subject to the same complications that are brought about by differences in testing strategies. And so here again, you can see that we appear in Ontario to be roughly in line with the rest of Canada and to be roughly in line with the United States. But of course, once again, we will continue to watch this extremely carefully. It is important to acknowledge at this point that a great deal has already been done in this province that will help limit the eventual death toll from COVID. So if, for example, we go back as far as March the 12th, we had the closure of public schools. Rapidly after, there have been a series of other measures. For example, limiting visitations to long-term care, looking carefully at those who are in short-term in and out arrangements with correctional facilities, and prohibiting large gatherings of over 250. By March the 16th, people were being told to practice social distancing. Travelers from outside Canada were being told to self-isolate for 14 days. The prohibition on gatherings was dropped to 50. And people were told to work virtually wherever possible. By March the 17th, we had the closure of public gathering places and establishment. By March the 21st, redeployment for healthcare professionals. And then rapidly in succession on the 23rd, 24th, and 25th of March, the closure of non-essential workplaces, work deployment for LTC homes, and the prohibition of gatherings of more than groups of 5 people. Most recently, we have seen enhanced capacity for contact tracing being rapidly put in place. We have seen the closure of parks and outdoor recreational facilities, and people have been instructed to limit outings to essential needs. Self-isolation for individuals over 70 and those who have underlying medical conditions or who are immunocompromised has been very strongly recommended. We also have had extended school closures. I'm now going to pass across to Steny Brown.
Thank you. I want to just start on slide 9 for those who are following on with slides and talk a little bit about some of the caution with which any models need to be interpreted. They're really used to help us plan what could happen, but I say this with very great seriousness, they are always an abstraction of what we're dealing with, and the farther out we go, the more uncertainty there is. We've used assumptions based on what we've seen in other outbreaks of COVID-19 and what we can gather from data around Canada as well to try to inform the model. And then we model how it spreads, and we do this based on standard epidemiological models where we can. We try to make assumptions about how quickly, or make estimates of how quickly and how widely the disease will spread. Critical to say that we'll talk about what would have happened had we done nothing. We'll talk about what may happen now, given the public health interventions that are in place. And we'll also talk about what could happen if we had enhanced measures to continue this or to try to suppress the disease as far as we can. It's important to note, though, these measures only work if people follow them. And so the assumptions that are in place here are assumptions about people working to make sure that they stay safe and keep the people around them safe. And it's important to note well that if there are people with COVID-19 infections moving between healthcare facilities or other places where there's many people living at the same time, there could be larger outbreaks. Going along to the next slide, which is slide 10, you'll see the curves that look at the different countries that Dr. Donnelly's already talked to. I just want to lay out that the Ontario curve is shorter because of a shorter period of experience with the disease. But that point way on the far point there of a significant number of deaths, almost 100,000 deaths, is an estimate of what we might be looking at within 30 days had we not taken the initial measures. And I talk about what this case would be like had we not taken measures, because I think it's important to convey the seriousness of the threat presented by COVID-19, and also the issue that were we to relax or to assume that we were in safe territory now, this is a disease that can rear back very quickly. But you can see here 100,000 cases within 30 days had we not done anything. If you go to slide 11, you'll see a little more clear representation of this. The 300,000 cases with a lot of growth right there. The current intervention, what we mean there in the middle is that there is a substantial reduction given our public health interventions in place, but perhaps still about 80,000 cases that we might see if the disease continues to grow as it does in other jurisdictions. But looking at cases here, 12,500 roughly cases we'd expect by the end of the month if we take new enhanced measures to suppress the disease. If you go on to slide 12, you'll see a similar presentation of deaths here. Had we taken no action, again, even within the short 30-day period between here and now, you'd be looking at up to 6,000 deaths. Thankfully, there have been some actions taken, and this leads us to a current estimate of about 1,600 deaths, so a substantial reduction in the number of deaths over the month of April. But were we to put in significant, actually I misspoke, 1,600 deaths that would have occurred from cases that developed during the month of April. But were we to take strong action now, the number of deaths that we'd be looking at from cases that developed during the month of April would be much lower, at around 250 in the future intervention. With that, I'll turn it back over to Dr. Donnelly.
Steny, thank you. Ladies and gentlemen, as Steny has correctly pointed out, projections and modeling of a brand new viral disease are very inexact. But what is important is that we use them early and quickly to advise us as to the correct measures to take, and that is what has happened in Ontario. I want to turn now to perhaps what might be the most disturbing slide in this deck for those who have the deck to hand, and that is the slide which is on page 13. I think it's important that we all are robustly realistic about the scale of the challenge that we face. And what this slide shows is the projection by Public Health Ontario, which is in line with that of other highly credible modelers, that says that over the full course of this pandemic, which may last for 18 months or even 2 years, because we may have a smaller secondary or tertiary wave, over the full 2-year course of the pandemic, had we done nothing, Ontario may have suffered 100,000 deaths. Thankfully, that is not the position that we are in, because of the very detailed actions that I read out to you before, which have been taken in response to emerging science. We believe that if we do all that we can get a much better end result for the province. It is not possible to be exact about where we will end up. But I think it is reasonable to say that if we do everything that we can think of, everything that already has been done stays in place, all of the other measures which are being considered put in place, that I think we could reduce the death toll in Ontario to somewhere between 3,000 and 15,000. There is a range, because where we end up depends on all of us. If we follow the rules, if we do our best to socially distance, if we look after the elderly and the vulnerable in our society, we can get within that range, and we can strive to get as low as possible within that range. So I appreciate that to many people, these will be shocking figures. But the important thing to stress again is that effective actions have been put in place, remain in place, and further actions are being proposed and are being taken. Now, we need to turn at this point to the important issue of all of the preparedness work which has been going on within Ontario Health Services. So I'm going to turn to Matt Anderson from Ontario Health.
Thank you, Dr. Donnelly. Good afternoon, everyone. For those who are following with the slides, I have one slide, and this is the slide on ICU capacity in Ontario. We use this slide as I think we all know. There are many different components to our health system. It is a very big system. This is a bellwether measure for us as we think about how do we get a sense of our preparedness and our readiness for this pandemic within our healthcare system. So the ICU capacity is a good measure for us. If you don't have the slide, what this describes is two curves, much like you saw from Dr. Donnelly and Dr. Brown. This is a slightly different data set because we update this every day, so tomorrow's numbers will be different than today's. But we do look at, do we have the capacity in our system to be able to support the people who are going to need our wonderful healthcare system? Right now, and what you would see if you have the slide, is there's two lines on there. One is the amount of capacity we have in our system today. The other is the amount of capacity that we can surge to today. We continue to try to move that second line up. We want to get as much capacity in our healthcare system as we can develop in the very short time periods that we're discussing. There are two bar charts, however, on this slide that are most telling. The first one, which is in blue, shows that is our best case scenario given the data that we have at the moment, given the projections that you've just heard from Dr. Donnelly and Dr. Brown. And what's core about that is that that line brushes right up against what we are able to expand our healthcare system to today, at least as it relates to critical care capacity. The other bar chart is what happens if we do not adhere to our social distancing. And if we start down the paths that you've heard described between Dr. Donnelly and Dr. Brown of not containing this disease and this disease growing more rapidly, and what you can see from the slides is fairly soon, in the April to sort of early May timeframe, it'll push beyond the capacity that we can bring. I would say that both on ICU capacity and on the entire system, your healthcare system, all of our wonderful people who work in it, we are trying everything we can to continue to increase the capacity that we have to respond to this disease. However, as you've already heard, we need everyone to play their part. We have to try to keep the prevalence of this disease to a minimum to allow our healthcare system to be able to support those who need it. Thank you.
Matt, thank you. Just 2 more slides from me, and then we'll pause and take your questions. So people ask how one slows the spread. And I need to introduce you to what sounds like a complicated concept, but really is not. It's the so-called reproductive number, or the effective reproductive number of this virus. And it's actually a lot simpler than it sounds, but it's worth thinking about, because I think it helps us all understand what we should do. So if I was sitting here with COVID and I managed to give it to my 2 colleagues, that would mean that I had contributed to a reproductive number of 2. And if they then gave it to 2 colleagues again, you can very quickly see how the disease continues to grow at pace. If, on the other hand, my 2 colleagues both had COVID, but through proper social distancing and proper hand hygiene, etc., they managed, one of them to give it nobody and one just to give to me, you can see that the reproductive number then is less than 1, it's 0.5. And of course, what happens then is that the disease begins to peter out. So it's about breaking the chain of infection. And it's very important that every one of us realize that we have a personal responsibility and a personal opportunity to do that. So we need people to stay home, to stay focused, to stop the spread, and to stay safe. Everybody needs to fully adhere to the public health measures that are put in place, because we want to avoid overwhelming the health service in the way that Matt has just described, and the way that tragically you will see reported on the news media from around the world. So bearing down heavily on this disease now saves lives, allows our health system to cope, and also helps the economy. And this is not widely recognized, but is important. There is convincing research that suggests that if you bear down hard at this point, it actually brings the disease to an end more quickly, and it allows the economy to bounce back. So there is no dilemma between saving lives and saving the economy. Bearing down hard now achieves both things. Finally, I need to run through a number of immediate focus, additional public health measures, and also future measures which are coming. So the first thing that is very much being worked on as we speak is enhanced capacity for case and contact tracing. In jurisdictions elsewhere in the world that have done particularly well, this has been very important. It's about breaking the chain by assertively chasing down cases and their contacts. There is a small army of federal employees, medical students and others being assembled to actually address this issue. They will be working closely with Public Health Ontario, with the Ministry of Health, with Ontario Health, but particularly with the public health units in the province. The second thing is increased testing due to very impressive efforts by frontline lab staff and lab leadership, not just at Public Health Ontario, but across the province in many of our hospitals. We have now eliminated the backlog of tests. That is important because that now allows us to use tests in a very focused and strategic way. For example, testing residents of long-term care homes and their carers needs to be a priority. As we have tragically seen, if you get even one case in a long-term care home, it is very easy for it to spread very quickly and to bring about many deaths. So we need to use our testing strategically to protect the elderly and the vulnerable. We need to use our testing strategically to protect healthcare workers, to protect our hospitals, to track symptomatic contacts of cases, and taken as a whole, we need to use testing as a subcomponent of our strategy to drive down the infection. Future measures include the further reduction in the number and types of essential workplaces. This has to be done carefully, and everybody understands this, I think. Those who would cry, simply shut everything down, need to remember that we need our nurses and doctors and healthcare workers to get to work. We need our laboratory workers to get to the labs. And we need transport to operate to get people there. The public need to be able to get groceries, pharmacy supplies, and other essentials of life. So reducing the number and types of essential workplaces is something that needs to be done carefully and thoughtfully. There will be an enhanced focus on enforcement and fines for non-compliance. Physical distancing guidelines will be further enhanced, particularly with regard to retail settings. It is essential that we provide enhanced support for the elderly, for the homeless, for vulnerable populations, and for communities. The concept of a ring of steel around long-term care homes is important. I applaud those jurisdictions who have proactively moved to house the homeless in accommodation which may prove life-saving. Many First Nations communities are looking very carefully about overcrowding in housing, and again, I welcome the approach that some public health units have taken in working with First Nations to reduce overcrowding and therefore to reduce vulnerability. Some First Nations are looking at entry restrictions to their territory. Human resource management is going to continue to be important. We have to protect our healthcare workers. We have to allow them to look after us. We are exploring rapidly use of technology to reinforce self-isolation, including, for example, alerts, and additional public education and communication will be forthcoming. Once again, in summary, and then I will stop for your questions to any of the three of us, we need to bear down heavily on this disease now because it will save lives, it will allow our healthcare system to cope, and ultimately it will be the best way to help our economy bounce back. I'm happy at that point to pause, and we will do our best to answer any questions you might have.
Okay, so just a reminder for everyone on the line, the Premier's press conference has been pushed back to 2 p.m. now, and we're going to take questions until 1:45. I'm just going to remind the speakers, before you answer a question, please just say your name. And now we're going to open the lines for the first caller.
Your first question comes from Mike Mike Crawley with CBC News. Please go ahead.
Hi. My question is for Dr. Donnelly. Dr. Donnelly, I've heard from lots of different sources that the reason that these projections were not made earlier is because the data coming from Ontario has been incredibly slow, and because of all the delays in the testing and the delays in getting test results out there. How do you respond to Public Health Ontario's own responsibility in the shortcomings of Ontario's testing regime and the shortcomings of Ontario's transparency with this data?
Mike, it's not true that the projections in terms of mortality were at all delayed. The projections in terms of mortality are not dependent on testing data in the first instance. It is entirely possible, and this is what we did, to make projections in terms of mortality based on the global experience thus far of COVID. And so the presentation to the command of what at that time was our best estimate of worst case scenario mortality, which at that time was 91,000. I know you understand that this is not an exact science, but we predicted right back at the beginning of March that the mortality could be that high based on global experiences, and presenting to command in that way led to the immediate decision to bring about school closures. And beyond that, I have articulated all of the various measures that have been taken. These have all been taken in response to an assessment of where the province was. Public Health Ontario has the role in this situation of communicating science right into the heart of the decision-making process. It is important for everybody to understand that Public Health Ontario has done that fearlessly, will continue to do that fearlessly, and what's more, that is what our political leaders want. I have personally briefed the Premier and the Health Minister. They listened respectfully, they were very thoughtful, they are utterly committed to getting this right. I personally sit on both the command table and the executive command table, and so I have direct access on a day-to-day basis to the three co-chairs of that command table. Helen Angus, the Deputy Minister, Matt Anderson, who's sitting on my right, the head of Ontario Health, and Dr. David Williams, the Chief Medical Officer. So science has been to the fore in informing the response of the command table during this epidemic.
Okay, we'll just take a very brief follow-up.
Okay. I didn't hear an answer responding to the question about the delays in testing. And my understanding is that the data was not actually provided to the people doing the modeling, the epidemiologists doing the modeling, until late last night. So if you could please respond directly to those two specific things, the delays in testing and the delivery of the data that the epidemiologists needed to do all of this modeling.
Sure, happy to do so. The release of data is a thing that only the ministry can do. The ministry has decided to release data to anybody who wishes to model this disease. I think that's a very sensible thing. Modeling as you move through this epidemic will become increasingly complicated, and we will need to draw on the very best brains. And so I think it's very wise that all of the data is being made available. But once again, the early projections of mortality were made were provided right into the heart of this process, and so they determined the policy response. Your second point about testing is also important. Public Health Ontario, as the regional reference lab, has ramped up its testing capacity considerably. But this is an unprecedented situation where we have required everyone to become involved. And there is now a very strong cross-provincial approach, which means that the testing capacity in the province is greatly enhanced. As I said, that means that the backlog has now been eliminated. It is true that there were challenges earlier on with testing related to a global shortage of some of the key reagents. That is something that needed to be overcome with Herculean efforts by many in the system. And I think it has been very heartening to see how all of the system has pulled together, has secured the necessary materials to do this testing, and it's great that we now have eliminated our backlog and that we can test in a strategic way.
Okay, we'll move on to the next question.
Your next question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Dr. Donnelly, I'm wondering if you can walk us through the that range there of projections for deaths, 3,000 to 15,000, in a little bit more detail. Obviously, you acknowledge that this is a pretty wide range, but I think that's the number that most people are going to look at here, and probably be a bit concerned about, afraid about. How specifically can the province push that to the low end here of 3,000?
Yeah, a very good question and a very good challenge to us all. Let me give you a little bit of context, because I appreciate that people will feel that even a range of 3,000 to 15,000 may seem not just scary and intimidating, but to many people unlikely. And so I just need everyone at this point to pause and consider carefully the following: that every year in Ontario, we lose about 1,350 individuals to normal seasonal flu. So in a bad year, we may well lose 1,500 to normal seasonal flu. Now, when you think that the mortality of this disease is up to 10 times higher, and when you remember that we have no vaccine, we have no specific treatment, and this is a disease which is entirely new to the population, then suddenly the figure of 15,000 becomes entirely logical and comprehensible. Now, that being said, we have in place, as we've just discussed, a lot of social distancing measures. That, taken along with the other public health initiatives that I referred to, pushes back, if you like, in the other way. So the best answer I can give you in terms of how we get closer to 3,000 and 50,000 is that we need to bear down. We need to do all of the things that we're doing and these additional things that I mentioned.
Follow-up?
On the high end there, the 100,000 deaths that were possible, I gather that this means in absence of any measures whatsoever to address this issue.
That is correct, and thank you for pointing that out, because I do appreciate that people will find that figure understandably alarming. So let me use your question just to state again very clearly that that is not where we are. That is not what we believe is going to happen. But that is why we needed to do all the things that we have done thus far, and it's why we need to continue to bear down. If we all do a good job, if we all stick to these measures, we can get an end result somewhere between 3 and 15,000. That is our closest estimate. We will, of course, watch carefully for sophisticated emerging models as we move forward with this epidemic.
Okay, we'll move to the next caller.
Your next question comes from Cynthia Mulligan with City TV. Please go ahead.
Hi, Doctor. Could you spell out more what the average person needs to do? And does there need to be a full-on lockdown? Do the Emergency Measures Act need to be put in place?
So the average person needs to do the things that they have been asked to do. They need to maintain physical distance from others. They should stay at home unless they are an essential worker or when they need to go out for essential tasks. And those essential tasks need to be very tightly defined. So in other words, it is to get food, it is to get pharmacy supplies if those otherwise cannot be delivered. If people wish to go out and exercise, and I do understand why in this situation people might want to do that, it is imperative that they do that on their own or perhaps as a couple or very small group with whom they already live. It is not appropriate if one is out walking to stop in the normal way and speak to neighbors or strangers because you need to maintain social distancing. People need to maintain hand hygiene. They need to wash their hands regularly with soap and water. They need to use alcohol-based antibacterial agents when soap and water isn't available. Those are the most basic personal things that people can do.
I just want to remind everyone on the line to please try and keep your questions to what's on the slides. The Premier and the Minister will be able to answer further questions later. Cynthia, follow-up?
Well, I'm sorry, but my follow-up is, Doctor, Ontario has done, per population, half the tests that Quebec has. Do we have an accurate figure here, or as much information as you need to do these projections?
That is a very good question. And what that points out again is that you shouldn't simply do projections based on test-confirmed cases. It's also important to look at projections which are based on other things. Sadly, in countries that are further on with the epidemic, there are a mounting number of deaths. And in that situation, what you track over time is deaths. Because deaths are not subject to what would technically be called testing bias. In other words, to any distortion that might be brought to the system because of the way in which you test. So we have used various ways of looking at this, and so we are confident that the overall mortality that we referred to and the target mortality that we're now tracking towards, that is not affected by the number of tests or the way in which the tests are being done.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, Dr. Donnelly. Just a quick question on the model. I'm wondering about it because, and I'm not challenging it, I'm just looking for an explanation. We know that there are probably hundreds or thousands more people who have COVID-19 that have been tested because not everybody's getting tested. So how many people do you assume have this beyond those who have tested positive? And is there a factor you use? Like, is it 5 times the testing number or 10 times the testing number?
Again, that's a great question. There are some models that actually work on that basis, that, if you like, they make assumptions about how many, if you could call them unknown cases, are out there. And look, let's be honest and frank. There clearly are many cases in the province that we don't know about. That must be the case because the evidence from around the world suggests that many people, particularly younger people, can have this disease in a very mild form. They hardly realize that they've got it, and therefore the danger is that they can spread it to someone else quite innocently. But again, these models, in terms of a worst-case projection and in terms of where we now think we are headed, are not dependent upon that sort of data. Modeling and projecting is a very inexact science. In the early days of an epidemic, it's all about providing an important early steer to policymakers about what they should be doing. And that's what happened in Ontario, because as soon as Command Table saw the figures that suggested that there could be an overall mortality of between 90 and 100,000, they moved very quickly to shut the schools, which was the right thing to do. Can I just, through our moderator, just remind journalist colleagues that I do have two fellow panelists here with me. I think because the camera is just focused on one person at a time, you might be missing the fact that there are some experts both from the university side and from the health service side who you may also wish to ask some questions of.
Okay, follow-up?
Yes, thanks for that explanation, Doctor. Just quickly, though, what is the factor that you would estimate? You know, we have about, low 3,000s, 3,400 cases confirmed now. What would you extrapolate from that as to the number of actual cases out there?
Honestly, I think that's very, very difficult to say because that is a product of what your exact testing strategy is at any one time. And there's another factor in Ontario which is important to mention, and I'm sure you're aware of, but that is our returning travelers from overseas. So if I can use particularly the example of the so-called snowbirds, who many of whom overwinter in the United States and then travel back to Ontario. And of course, that is a very challenging problem for us and one that we need help from those individuals with. Because I think it's very clear that in many parts of the United States, this disease is highly prevalent. And so many of these people, again, quite innocently, can travel back from the United States and perhaps don't realize that they are carrying the disease. And this is why these people must stay at home for 2 weeks. They must go directly to their home when they come from the airport or other port of entry. They should not be stopping to do shopping or anything else on the way home. Whilst they are at home, they must absolutely reduce to as close to zero as possible their contact with other individuals. I'm sure you all see the importance of this, which is that otherwise these individuals could inadvertently seed this disease all over Ontario. So if you know snowbirds, if you have snowbirds as neighbors, please help them out. Please drop shopping for them. Please drop pharmacy supplies for them. Please help them to do what I'm sure they want to do, which is to keep everybody else safe.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Hi, doctors. I wanted to ask about that projection, the 3,000 to 15,000 projection, which I understand the range there depends on the distance measures, what we bring in, and how well we adhere to them. But can you talk a little bit more about how you came up with those boundaries and what level of confidence you have in those boundaries?
Well, those figures relate to the entire course of the disease, which may be, as I say, over 2 years. What people don't necessarily realize is that with an epidemic like this, you can have a second or even sometimes a small third wave. And so if you see figures which are less than this, a lot less than this, it may be because people are only looking at the first wave, or it may be, as Steny Brown was explaining earlier on, that the particular model that he was speaking to is a model that is focused on the short term. All of these models work in a complementary way. The sort of projections that I'm talking about, the 100 down to somewhere between 3 and 15, the purpose of that is to drive high-level public health measures. The purpose of the sort of model that Steny Brown was talking about is to inform the work of people like Matt Anderson and his hospital colleagues in terms of preparing the healthcare system. So I think it might be useful at this point for me to throw this across to Steny to talk about the way that sophisticated model he was referring to operates, and it may be that there's a contribution that Matt would want to make about how modeling actually allows us to take an informed view on issues such as how many ventilators we might need. So Steny first.
I'm not sure I could help on the
No?
3
Okay.
sorry.
Okay. So anything you want to add, Matt, on the use of models to inform healthcare preparedness and planning?
Sure, and I don't know if it's direct to the question, but as Dr. Donnelly has said, for us, as we think about how do we create the capacity that's going to be required, while we appreciate that the models can move, and as I mentioned in my talk, that first slide, we update that daily to try to maintain a view as to where do we need to get to support the system. As Dr. Donnelly has described, that can move around quite a bit. It's still helpful for us as we think about what is the scale that we need to move to make sure that we're creating a system that can support, and of course, as you've heard, and I think there's been the theme throughout this meeting, where that model ultimately goes, what these numbers ultimately come back to, largely comes down to how well did we do as citizens to adhere to the social distancing. We have that power, and we have to execute that to keep our numbers as low as possible.
Quick follow-up?
And just connected to the point that you were making there, the 18-month to 2-year horizon, does the model assume the same level of distancing measures, or does it assume that over that time, as we get from first wave to second wave, that these measures are lifted in some way?
Yeah, great question. You're now getting into a very complicated future scenario that truly will require very sophisticated models and the very best scientific brains to look at this. Look, what we're trying to do at the minute is to drive down, as I explained, the effective reproductive number of the virus to below 1. So this is not simply now about flattening the curve. This is about chopping the top off the curve. This is really about taking measures that drive down the number of deaths, the pressure on the health service. And the idea of that is that it not only does those two good things, but it does allow the potential, if you actually completely suppress the disease, to look very carefully around the province and to see whether there are places where it might be possible to selectively lift some of the social distancing measures. I need to say that we are some way off before we could do that. But the time to start thinking about that now is now. The time to start thinking about how modeling could inform that is now. And there are various things that you can do, including background serological testing, because the assumption that most of the world is working to, and we have to believe is correct, is that this is a disease that we will only get once. And so if you do background serological testing, which doesn't tell you about whether you have the disease today, but tells you about whether you've had it in the preceding weeks and months, that can actually be very helpful, because in a place where there's very little background evidence of infection, you clearly would need to be very, very careful about lifting social measures, because there is still a large proportion of the population who are vulnerable. Whereas in a place probably more like the GTA, where we have most of our cases and sadly most of our deaths, then it might turn out that when we actually look at this, there is a higher level of background infection. And if enough people have got this disease and are now immune to it, you do effectively move closer towards a situation where you would have what's called herd immunity. And what that does is that it stops the chain, it breaks the chain, because when you have somebody who is infected, most of the people who they come up against have themselves already had the disease and therefore are not going to get it again. So you can see that the way in which you might lift social measures, the timing of when you did that is going to have to be driven by some very complicated modeling, some really quite complicated science, and is going to have to be done in a very thoughtful and disciplined way.
Okay, next question.
Your next question comes from Antonella Artuso with the Toronto Sun. Please go ahead.
Thank you. Hello.
Hi.
Does any of the modeling consider the general population donning some kind of mask?
These models have not. In general, the accepted science in terms of masks has been that they really are best preserved for frontline healthcare staff and for other appropriate frontline healthcare providers. I am aware that in some other parts of the world, it has become more and more common for the general public to wear masks. And we need to keep watching the evidence on this and what other places do. But in general, with masks, it's not so much that it protects the wearer, other than in a frontline healthcare setting. It really is more about protecting other people from an individual if that individual is themselves symptomatic. I mean, simplistically, it stops them coughing or sneezing over someone. But of course, the person who is symptomatic, the person who is coughing and sneezing, shouldn't be out anyway. They should be self-isolating. They should be at home. Now, that doesn't mean that if you see somebody with a mask, you should panic and assume that they have COVID. That will almost certainly not be the case, because I think people largely are following, thankfully, the injunction to stay home if they are unwell. But there are differences, national, cultural, in terms of mask wearing. I think masks in our current situation should be preserved for those who need it most, our highly valuable frontline healthcare workers and other emergency workers. Matt, you've been very involved in the PPE issue, the supply chain. I don't know if there's anything you would want to add.
Thank you, Peter. I think I would just add that PPE and supply chain, this is obviously our biggest challenge in our healthcare system right now as we look to our preparations. We have sort of a significant effort going on federally, provincially, within all of our agencies to secure more PPE. We're also encouraging conservation methodologies across our system. But at the end of the day, and going back to Dr. Donnelly's original point, the most important thing here is the safety of our healthcare workers, the people that they serve, our patients and families, and we move everything in that direction to support them. Thank you.
Follow-up?
Thank you. The worst case scenario, the scary number, the 100,000 dead, that
seems to be avoided through full social distancing measures for a long time. I'm wondering, are you aware of any jurisdiction that has successfully been able to socially distance themselves for more than a year or 2 years?
It's another great question. Look, I think people need to realize that these are truly, truly unprecedented times. People have tried to think about historical examples when social distancing was requested and complied with. And some people will point back to polio epidemics in the past. But even then, it wasn't on the scale that we're now having to apply. And so when people reach for historical precedent here, they actually have to go back over 100 years. They have to go back to the great influenza pandemic of 1918, when some places did undertake the sort of social distancing and other public health measures that we've been talking about today. The interesting thing about that is that when you read the history papers, and there's a very good one just a few days ago actually, not written by public health people, written by economists, who looked at the effect of those places in the United States who had gone very rapidly for very rigorous social distancing measures. So in other words, the places that had closed the schools early and taken other necessary steps. And the interesting thing is that there's a huge difference if you then look at the mortality in those states. And fascinatingly, there's a difference in terms of the way that those states bounce back economically. It seems that there is genuinely no dilemma between saving lives and saving the economy. The smart, science-based thing to do is to bear down heavily, to protect the vulnerable, and therefore to get through this more quickly than you would otherwise do, so that the economy of your area can bounce back.
Next question.
Your next question comes from Christina Tenalia with CP24. Please go ahead.
Hi there. Thank you so much for taking my question. Doctors, I'm wondering if you can provide some guidance on this. When we consider that Toronto is the largest city in the province, and you look at the projected numbers in terms of the projected number of deaths, can you attribute them geographically? Can you attribute them to, say, because Toronto is the largest city, for example, people in this city could perhaps expect the largest potential number of deaths in Toronto?
So you would normally expect, of course, the largest number of deaths to happen in the places that have the largest population. And it's not surprising, therefore, that the largest number of cases we have and the largest number of deaths, all bar outbreaks in nursing homes outside the GTA, they are focused on Toronto and the GTA. But really the measures that one would take are the same. One bears down heavily whether you're in Toronto or whether you're in a smaller Ontario town. I do think there has been a very responsible attitude taken to try and ensure that federal government, provincial government, and Toronto city government try and keep very tightly in step, because clearly if that were not to be the case, I think the public would be confused if there were different rules in one place than somewhere else. And I do think that the politicians at all of those three levels, drawing on the science, have been very careful to try and stay in step to limit the number of deaths, whether that's in Toronto, the GTA, or elsewhere.
Follow-up?
Thank you, doctors. As the doctors who, of course, have the most information on this matter, I am already hearing, as you're speaking, concerns from doctors about the number of ICU beds. Can you just be clear, will there be enough ICU beds by Monday here in this province, and how quickly do you think the province can ramp up capacity?
So I'm going to turn to my right to Matt Anderson from Ontario Health. He and his team have been doing a lot of work in terms of ramping up capacity.
Great. Thank you for the question related to ICU capacity. So as I mentioned in my opening remarks, we right now have a little over 400 beds dedicated and open for COVID cases. We are able to grow that by another 900. That is the number that we have today. In terms of, also I would add that our current capacity across the province is at a little above 70% of our total ICU capacity. That's before we add the other additional beds. What we see, though, is that number of 70% is averaged across the province. So we do have to look at load balancing, meaning that there will be times when we will need to move equipment to places that need more equipment. Occasionally, we also need to move patients from one place to another to make sure that we've got the capacity required. In terms of your specific question of having capacity at a certain point in time, it again goes back to the points that have been raised by Dr. Donnelly and Dr. Brown on social distancing and managing the disease. If we can keep the prevalence of the disease to a lower level, the capacity that we have online or that we could bring online would indeed be sufficient. But if the capacity was to spike, or the need, pardon me, was to spike, that becomes very difficult for us, difficult to project. And so what we do, in addition to having the 900 additional machines, ventilators, that is, in beds, we're also looking at sourcing more as this disease goes on and as that trajectory is still in question. So we can get as much supply in as possible to meet whatever demands are coming our way.
Okay, we're going to move on, but just a note that unfortunately we're running short on time, so this will be the last caller.
Your final question comes from Travis Daharaj with Global News. Please go ahead.
Hi there, and any doctor can take this. It follows up on Christina's question. I'm looking at slide 14 here, the ICU capacity for COVID-19. So the green bar is the confirmed number of cases, and we know that, in the past, what has been projected and the reality of the situation is not aligned. And it looks as though in the short term, like next week, we may run out of ICU beds. So what is being done to, in the next week, get some of these beds online? And do you expect shortages in the meantime? And how long would you expect shortages for?
So it's Matt Anderson. I'm happy to take that question again. In the slide that you're referring to, there's two lines on there. The first line, which is the current open capacity. The second line is the additional capacity that we can surge up to in very short order. So if this chart were to bear itself out to be absolutely accurate, which I believe my modelers to the left of me would caution that that's not likely that it will play exactly this way. But if it did, we would be able to bring enough capacity online. Again, the challenge becomes twofold. One is, does the demand actually fit this curve? And certainly if it's the blue bars, that would be a good thing. If it is the orange bars, that is not a good thing. That becomes much more difficult for us to meet. The second is, what is the slope? We've got this modeled out. It could spike faster, which is another challenge for us for sure. And although I said two, I should say that the third element on all of this is matching where are these cases happening versus where do we have the capacity in the province. That is very difficult for us to model. One of the things that we have done to try to offset some of the risk associated to that is we have a provincial command table that is run by critical care docs and others to make sure that when a area in the province, if they find themselves in trouble, can call this line and we can work together to see, as I mentioned in the last question, is there either equipment that can be deployed to that area, or perhaps are there patients that can be moved to another nearby facility that has the equipment necessary. So there's many different things that we'll try to do to make sure that we've got the ventilator capacity, the ICU capacity in the province. Again, going back to the earlier comments from Dr. Donnelly and Dr. Brown, so much of this comes down to what is the rate of disease in our province? Are we following the social distancing rules? And are we doing everything we can to contribute to keeping the prevalence of this disease as low as possible?
So we know that
PPE
has been an issue in procurement in the past, and we know that a lot of healthcare workers have tested positive. As you know, President Trump is using the Defense Production Act to direct 3M to stop exporting masks to Canada. Will your projections change if we're not able to procure some of those N95 masks from the United States?
I think from a modeling perspective, I would have to hand that over to Peter or Staney to comment on whether that would change on the model. Is that?
Do you wish to comment, Staney?
Yeah, I'm happy. So anything that changes the supply that we're anticipating obviously reduces capacity, and as we look at a epidemic growing, that becomes a very, very, very tough place. I think the key issue is whether we're talking about ventilators, or we're talking about beds, we're talking about the people who are actually working, providing care, or we're talking about personal protective equipment. The single most important thing we can do right now is slow the spread of the disease, which then leads to fewer cases. And that's through the types of measures that we've talked about already in place, but also the other things that we can do in the province right now. That's probably the real key at this point, and the single most important thing that we can look at. But as you said, anything that reduces the supply in reduces the capacity we have here.
That's all we have time for, unfortunately. Thanks very much.